Today we're going to talk about chapter 52 which is obstetric measurements and gestational age. So let's start with first trimester. If we can't see an embryo, we will want to go ahead and measure the gestational sac. Sometimes in early pregnancy, especially like around 5 weeks, an embryo is not quite visualized yet. So we'll do like a 3-dimensional gestational sac measurement to see how far along a patient could be. The distended urinary bladder has an effect on gestational sac measurement. It changes the shape from round to ovoid to teardrop, as you guys have figured out by now that when the bladder is full, it does change the position of the uterus. If the sac is round, you measure 1 diameter inner to inner. And if the sac is ovoid, you make 2 measurements inner to inner. Now with at my job, and I think most places, they like to do a 3-dimensional sac measurement. So you'll take a height, AP, and width measurement, and that should calculate the dates. There's a picture of it. Now you can see this is the diameter. They did the 3 diameters here. They haven't done diameter 3 yet, but it will calculate the gestational sac measurement. And then the OOR means out of range. So they can't quite calculate a range until they do the 3rd diameter. Once they do that, then it should say like, well, 5 weeks, 6 days, or this looks like about almost a 6-week gestational sac. Oh, hey, look, I was right. I didn't even know that one was on there, but they finished up their diameter measurement and then it calculated it at 6 weeks, 6 days. These are some of the things that you need to know, your little cheat sheet there. So if you can see, if a patient has a 500 beta HCG, usually you can see a gestational sac. Usually around 1500 HCG is when you can potentially see like an embryo. If you see a greater than 8 millimeter gestational sac, then you should see a yolk sac. If it's doubled in size and it's a greater than 16 millimeter gestational sac, you should see an embryo. A yolk sac that's less than 6 millimeters is considered normal. If it's greater than 8 millimeters, it's considered abnormal and is usually at an increased risk for chromosomal defect. And if you have a fetal pole that's greater than 7 millimeters, you should have positive cardiac activity. So around like 6 to 12 weeks, or some people do 6 to 14 weeks because that's the first of 13 weeks, 6 days. 14 days, or 14 weeks is the first day of your second trimester, excuse me. We like to do the crown rump length. We don't do head, belly, and femur measurements yet because the baby's too small. So the most accurate thing that we can do is measure from the top of the head, which is the crown, to the bottom of the rump. And this is really the most accurate fetal age measurement. Most babies grow at the same same time. And so there's not going to be much discrepancy in fetal age in the first trimester. So look at this cute little baby here. And this is the top of the head to the booty. And so this is how you would measure crown rump length. Here is another picture here, and this is showing the nuchal translucency in the back, but you could also do a crown rump length here from the top of the head to the bottom. Here's another baby around 12 weeks. So you would do from the top of the head to the bottom. It's pretty easy measurement. Most students don't have any trouble doing this at all. Next up is the embryonic heart rate, and it can be measured by M-mode from early 5th to early 9th gestational weeks when the crown rump length is less than 25 millimeters. Now, like I've said before, I don't like you guys to put pulse wave on the first trimester scans because pulse wave is a higher intensity of sound waves. The heart is so small. So by general rule and following ALARA, we should only do M mode for heart rates. Now I do see the heart rate, the normal fetal heart rate accelerate up to 170, 180 in a normal fetus around 7 to 8 weeks, and then it seems to drop. If you do scan a fetus that is, or embryo that is 5 weeks, 6 days, or 5 weeks, 5 days, maybe 5 weeks, 4 days, the heart rate could have just started, and you'll get a lower heart rate around 100 beats per minute, but it should start accelerating throughout the first month. Now, if you remember from our last lecture, in the second trimester, you want a heart rate of 120 to 160 beats per minute. Sometimes the baby's heart rate will accelerate if they're moving around, and that's fine. We actually do want that, but it should always come back down to baseline at 120 to 160. Okay, so let's talk about our measurements for second and third trimester. When we are measuring a baby, let's say around 16 and above, 16 weeks and above, actually 14 weeks and above, we don't do the crown rump length anymore. We actually do 4 measurements, and then the machine calculates it with its awesome algorithm and spits out a date for us. And then we can see how the baby is growing. So this is what we're going to work on in lab later, is you guys learning how to measure the baby. So first thing we're going to do is obtain the biparietal leading edge to leading edge diameter of the head at a transverse level. So these are going to be your landmarks: the falx, the cavum, septum pellucida, and the thalamus. You want to make sure the head is symmetric and oval, and you measure from the outer to the inner margins of the skull. Now that's really important. So you measure from the outer skull to the inner skull. In the third trimester, the BPD is not as accurate in predicting fetal age, but in the second trimester it is. So here is a picture. I'm going to show you a couple of pictures. So let's talk about your landmarks first. Let me see here. I want to show you. Okay, so this is the thalamus right here. So that's going to be one of your landmarks. Then the line right here is going to be your falx. That's going to be your other landmark. Then these 3 little lines right here, that's a portion of the cavum, septum pellucida. So that's going to be your last landmark. So this is what you want the head to look like before you do the biparietal diameter and the head circumference. So to do the biparietal diameter, the BPD, you would start at, so you're measuring from side to side basically of the head. So you'd start from the outer part of the skull, and you would go straight down through the thalamus to the inner part of the skull. And that will calculate your dates. This is another image of just your landmarks here, your thalamus, the cavum septum, and then the calvaria, which is what you're going to be measuring. So you measure from the outer part of the skull to the inner part of the skull. I want you guys to really know that. Here's one more picture of a beautiful head measurement. And you want, for your biparietal diameter, from the leading edge of the skull to the leading edge of the skull, straight down through the thalamus in a perpendicular plane. Here's one more. I just really want you to get understand that the leading edge is very, very important part of measuring the head. Okay, so next up, after you do the biparietal diameter, your next image is going to be the head circumference. Now, fortunately, you can use the same plane that you used your biparietal diameter for your head measurement. And a lot of people just use the same picture, like we saw in a couple of the previous images. So you use the transverse plane at the level of the BPD and place the calipers along our outer margin of the skull to obtain a circumference. And it's going to be like this ellipse here. And it's just going to go around the skull here. Just like you're measuring the head, just like you measure an infant's head. It's a pretty easy measurement too. Sometimes they want at higher centers like MFM centers, not where you're going to start out at all. They will do a coronal head circumference for a different reason. And this is a plane perpendicular to the transverse head circumference. And the plane should include the thalamus and the brainstem. And you'll still place the area calipers at the mid edge of the skull to delineate the coronal triangle. Again, don't measure or worry about this too much because we don't do this measurement. So that's like looking more at like a coronal view because you can kind of see the brainstem and the thalamus. This is showing a dolichocephaly, and dolichocephaly means where the head is, the BPD is smaller, but the OFD, this occipital, the frontal diameter is longer, so that it's almost like a pancake. The head has been smashed a little bit, and sometimes this happens in a baby that is breech. Brachiocephaly is just the opposite, where the side of the biparietal diameter is larger, but the OFD, the occipital, the frontal diameter is shorter. And this can happen sometimes in Down syndrome. Okay, so far we have the biparietal diameter and the head circumference. The next thing that you're going to measure is abdominal circumference. And basically this is like taking the baby's waist and putting a belt around it. The abdominal circumference should be taken from the round transverse image, and these are your landmarks: perpendicular to the spine, and the umbilical portion of the left portal vein within the liver. Sometimes you can see the stomach, depending. The outer margin of the abdominal wall should be measured, and you definitely want to make sure that you are including the skin in your measurement. The abdominal wall measurement is the least accurate for fetal age. It seems because it just sometimes you can over or underestimate it. So this little baby, this is where you take it. You want to see the portal vein coming into the liver there, the stomach and the spine. Those are going to be your landmarks. Here you are. So it's like you're taking a belt and measuring it around. It's your abdominal circumference. You can see the spine. This black hole right here is the stomach. This is the umbilical vein. This is the liver right here. And the measurement goes all the way around, kind of including the skin. Next step after that is the femur measurement. And usually from the abdominal measurement, you just go towards the baby's bottom and the femur will pop right out. And it's a hypoechoic linear structure. You really can't miss it. And it represents the ossified portion of the femoral diaphysis and corresponds to the femoral length measurements from the greater trochanter to the femoral condyles. It's pretty easy measurement because it's just straight across. But one thing I want you to be sure of is to not include the distal femoral point. And I'll show you what that is in just a second. The normal femur has a straight lateral border and a curved medial border. And the femur length is about the same accuracy as the BPD. Now there are growth restrictions that can happen and skeletal dysplasias that would make the femur small, but if it's a normal femur, it should be about right on with your gestational age. Okay, so here's a white bone. It's pretty easy to see, so you'll do from the top to the bottom. You don't want to include this point though. That'll mess up your measurement, and that's the diaphysis point there. And you will see that on all of the babies that you scan later in the second to third trimester, and you just don't want to include that point when you see it. Include the shaft. If there is this, these are not measurements that we do all the time in the general population, but if there is a concern about a skeletal dysplasia or growth of the baby's bones, we start doing measurements of all the long bones. And the first one we do would be the tibia and the fibula. The tibia is longer than the fibula. The fibula is lateral to the tibia and thinner. And you measure length point to point. So we would start measuring all the long bones of the baby, which you can imagine is kind of hard when they're jumping around in there, making sure they're on the right leg and the left leg. So sometimes measuring all these bones can take a little bit of time. At our site where I work, we always include the humerus measurement too. It's pretty easy to see. It's just the upper arm bone. And you image the fetal spine in the upper thoracic, lower cervical region, identify the scapula and rotate the transducer. And then the humerus should pop up. Now, you don't want to include the proximal humeral point in this one. So any kind of pointy part of the bone that's coming off the bone, don't include. You want to include the shaft. So you don't want to include this pointy area because that'll mess up your measurement, but include the shaft of the bone. Again, with the radius and ulna measurements, it's going to be the same thing. The ulna is longer than the radius. They're the same distally and they measure length from point to point. However, we do not generally do those unless we're looking for some kind of dysplasia. But here they are. If a baby is at a risk for some kind of hypotelorism, hypertelorism, those occur with chromosome anomalies where the orbits are closer or too far apart. We'll do an orbital diameter measurement, and you measure from the outer to the outer diameter and then to the inner, and then it calculates. And then your doctor can figure out if it's too far apart or too close. However, too close is pretty easy to see, and you don't really have to do measurements to make sure that happens because it's just so obvious. This is a cute baby. Those eyes look about right. So this is what we're talking about, outer to outer dimension of the eyes and inner to inner. Again, these look like pretty good spaced orbits. We always include this cerebellar dimension, and it's in the posterior fossa. So you obtain the biparietal diameter where the cavum, septum, flusta, I'm just going to say CSP, you guys know that now, and thalamus, and you angle the transducer inferior towards the base of the skull and you image the posterior fossa. The cerebellum actually is amazing at determining gestational age. So let me show you this. This is the cerebellum here. So you'll measure, it's the peanut looking thing in the brainstem. I kind of love how the cerebellum always looks, especially at 20 weeks. So you'll measure from side to side. Then the back of the cerebellum, you'll measure the cisterna magna from the vermis to the occipital bone. And that's it with that.